Bismillahirrahmanirrahim. Hello everyone. I'm Professor Dr. Dramirgilani. I'm working as Dean of Faculty of Allied Health Sciences at University of Lahore in the city of Lahore in Pakistan. Our today's speaker is Dr. Muhammad Ibrahim, who is MBBS and PhD. He's working as head of ultrasound department at Community Hospital and lecturer at the University of Hargeisa in Somaliland. I am glad to share that he is one of my students when I was teaching in Al-Zaim Al-Azhari University in Khartoum, Sudan. Glad to see him with PhD, with MBBS, and now he is our invited speaker. He is going to speak on ultrasound for diagnosis of ectopic pregnancy. Without wasting time, I would like to request Dr. Muhammad Ibrahim Ali to start his presentation. So mic is to you, Dr. Muhammad Ibrahim, please.
Thank you, Prof. And thank you and welcome for all attendees in all over the world. However you are following us and however you are watching this presentation. And in this presentation, I would like to talk about ultrasound evaluation of ectopic pregnancy. And I will talk about definition of ectopic pregnancy, factors and figures of ectopic pregnancy, signs and symptoms of ectopic pregnancy, locations of ectopic pregnancy, beta HCG discriminatory level, and how to use it with the correlation of ultrasound. We will see a spectrum of sonographic findings. We will discuss pitfalls and confusions related to the ultrasound findings of ectopic pregnancy. And finally, we will talk about the unusual locations of ectopic pregnancy. So, what is the ectopic pregnancy? Ectopic pregnancy is any pregnancy implanted in any location other than the endometrium, the endometrial cavity. The normal position of the gestational sac is at the fundus or middle portion of the uterus. It has eccentric position within the endometrial cavity. Sometimes pregnancy could be in the uterus, but is still considered ectopic pregnancy, especially if it is in the cervix or C-section scar area. So here is the normal position of the gestational sac at the fundus. Off center, not within the endometrial cavity, but off center, and this will give two echogenic lines. These two echogenic lines are decidual capsulars that line the gestational sac, and decidua parietals that is lining the endometrium. And between these two lines, there is a hypoechoic line, which is the endometrium. This is called double decidual sac sign. Factors and figures of related to the ectopic pregnancy. Ectopic pregnancy incidence is 20 per 1,000 pregnancies, or simply we can say it is 2%. Hemorrhage from ectopic pregnancies is still the leading cause of pregnancy-related maternal deaths in the first trimester, and accounted for 4 to 10% of all pregnancy-related deaths. Up to 30% of patients with an ectopic pregnancy will have repeated ectopic pregnancy, which will affect future fertility. Signs and symptoms of ectopic pregnancy. Vaginal bleeding is seen in 85% of ectopic pregnancy patients, lower abdominal pain in 90%, and adnexal mass in 65%. These symptoms are non-specific, even with the positive pregnancy test and amenorrhea. Therefore, the first question, whenever you see a patient bleeding, the first question is to confirm if she is pregnant or not. If she is pregnant, then think of ectopic pregnancy. But if she is not pregnant, then you can think of hemorrhagic ovarian cyst, ruptured ovarian cyst, ovarian torsion, or PID. because these symptoms, this disease can show also same symptoms of ectopic pregnancy. But keep in mind that even with a positive pregnancy test and amenorrhea, 70 to 90% of patients with suspected signs and symptoms turn out to have intrauterine pregnancy, normal intrauterine pregnancy or abnormal intrauterine pregnancy. Locations of ectopic pregnancy. Most of the ectopic pregnancies are implanted at the fallopian tube, especially in the ampullary portion. Rare cases are implanted in the cervix, Cesarean section, or ovaries, or even in the abdomen. These are very rare cases, or sometimes sometimes very rare case in the upper abdomen, in the upper side of the abdomen. Ectopic pregnancy. Risk factors of ectopic pregnancy are period ectopic pregnancy, PID, history of infertility, tubal surgery, intrauterine contraceptive device, endometriosis, increasing maternal age, and periodization. Techniques. There are two techniques to evaluate ectopic pregnancy: scanning transabdominally or scanning transvaginally. What is good with the transvaginal scan is that it has better resolution because transvaginal transducer frequency is higher than that of the transabdominal convex transducer, and it's positioned closer to the uterus and gestational sac and pelvic organs. Also, it advances 1 week of a transabdominal scan. On the other side, the transabdominal scan has better penetration, and because it has best for large abnormalities, it can be shown. It's recommended to start. On the other side, it is the transabdominal scan has better penetration, and because it has large field of view, it is good for large abnormalities. Therefore, it is recommended to start scanning transabdominally to have overview checkup of the pelvic organs and see if there is free fluid in the abdomen and an area of the hepatorenal angle. Then transvaginal scan is done to image the pelvic organs in detail. So what should you do? For ectopic pregnancy, it is recommended to focus on the areas, on 3 areas: uterus, adnexa, and cul-de-sac. Uterus is scanned to determine if there is intrauterine pregnancy or not. And the adnexa is scanned to look for any mass, and cul-de-sac is scanned to see if there is free fluid. What are you expecting to see in the ectopic pregnancy? Number 1, we are expecting to see empty uterus, which indicates the absence of the intrauterine pregnancy. Sometimes there might be a fluid as a hypoechoic area in the uterus, in the endometrium, and this is called pseudocyst. Number 2, there might be a live extrauterine embryo, and this is usually found in 8 to 25% of patients with ectopic pregnancy. Tubal ring present in 40 to 80% of ectopic pregnancy patients, and adnexal mass and free fluid in the pelvis or in the cul-de-sac. In a patient with a positive pregnancy test, an alarming sign of ectopic pregnancy, if you see an intrauterine pregnancy, it will exclude ectopic pregnancy. Because heterotopic pregnancy is very, very rare, rare. Risk to see a heterotopic pregnancy is 1 of 7,000, 1 in every 7,000 pregnancies in general population, and 1 in 100 pregnancies in patients conceived with reproductive techniques, with assisted reproductive techniques. Therefore, intrauterine pregnancy is highly suggestive of no ectopic pregnancy. Extrauterine mass with yolk sac and or embryo. And this is the most reliable evidence of ectopic pregnancy. It is a Extrauterine mass containing yolk sac and embryo with or without heartbeat. It is not the most reliable, it is not the most common, but it is the most reliable. And it can also, it has a positive predictive value of almost 100%. This is the uterus. Here you can see uterus. Small amount of fluid appears here in the endometrium. And just to the right side, to the right adnexa, you can see a gestational sac containing yolk sac and embryo. And here you can see with color Doppler, you can see there is a heartbeat, and also there is a free flow, there is some appearance of the fire ring around the gestational sac. And here you can see the uterus is empty, no fluid in the endometrial cavity. In the left side, we can see embryo with a crown drum length of 20 millimeters. The second evidence of ectopic pregnancy is to see what is now Bagel sign, which simply means gestational sac outside the uterus before it is ruptured or before yolk sac and embryos develop. Bagel sign is a donut-looking like lesion, tubal ring with thick and echogenic wall. It may show blood flow around the wall, giving ring fire appearance. It is said that it has positive predictive value of 95%. This is tubal ring outside the ovary and outside the uterus. At the left adnexa, it has thick and echogenic wall, no yolk sac or embryo in it. This indicates definitely ectopic pregnancy. Another case showing Bagel sign or donut looking like a lesion. This time wall is thicker and round shape. Make sure it is separate from the ovary. With a positive pregnancy test, this is ectopic pregnancy for sure. The most common finding indicating ectopic pregnancy is heterogeneous mass indicated at the adnexa outside the ovary. It is called Bagel sign, and it represents mostly hematoma and clots in the tube. It has positive predictive value of almost 2%. This is the ovary, less echogenic than the adjacent mass, and it demonstrates ovarian follicles. Here we can see well-defined mass outside the ovary with relatively homogeneous, likely due to blood clot around the ectopic sac within the fallopian tube. And another example of Bagel sign, relatively homogeneous, more echogenic than the adjacent ovary, and seems separate from the ovary. In most cases, especially in the third world and in Somalia especially, patients of ectopic pregnancy come with a ruptured tube, although ultrasound cannot determine rupture of tube, but it can show free fluid with clots in the pelvis. In a patient with positive pregnancy test, an empty uterus, seeing echogenic fluid in the pelvis or in the cul-de-sac is highly suggestive of ectopic pregnancy. 15% of ectopic pregnancies show free fluid in the pelvis, and 50 to 70% of ectopic pregnancies show free fluid along the other findings like tubal ring or adnexal mass. But also it is important to keep in mind that non-specific free fluid might be detected with normal intrauterine pregnancy, but this normal physiologic fluid is usually small in amount and not echogenic. This is with normal endometrium. Below the uterus in the cul-de-sac, you can see fluid with echogenic irregular objects representing clots. And here is another image showing free fluid in the cul-de-sac containing echogenic debris, suggestive of blood. Then let us see some pitfalls and confusions that might be faced when evaluating ectopic pregnancy. What about if you see empty uterus in a patient with positive beta-HCG and no evidence of ectopic pregnancy? And here, quantitative analysis of beta-HCG is very helpful. And it is very helpful also to correlate with the ultrasound. Beta-HCG is detected in serum as early as 7 to 8 days after ovulation when pregnancy occurs. In normal pregnancy, beta-HCG doubles every 48 hours and minimum 66% every 48 hours. One is beta-HCG is 1,000 to 2,000 milli-international unit per milliliter. Preparation, when using international preparation, we are expecting to see intrauterine pregnancy using transvaginal probe. But if no intrauterine pregnancy with beta-HCG above 2,000, then think of ectopic pregnancy, unless there are multiple gestational pregnancy or there is abortion. Sometimes you might see an intrauterine fluid collection with no yolk sac or embryo, and you need to decide if it is gestational sac or pseudo-gestational sac, because 10% of ectopic pregnancies are associated with pseudo-gestational sac and with pseudo-gestational sac. And then here we can see some tips to differentiate between gestational sac and pseudo-gestational sac. True gestational sac has eccentric position, not within the endometrial cavity, but offset of the endometrial cavity. It also shows double decidual sac sign, which is two echogenic line representing decidua capsularis and decidua varietalis, separated by the endometrium. But pseudo-gestational sac is intracavitary fluid, and endometrium might be thin and irregular. So look here a schematic draw of a true gestational sac showing layers of double decidual sac sign. And here in the ultrasound, you can see demonstrating two echogenic lines. One is circle, and this circle 360 degrees is the capsularis, is the decidua capsularis. This decidua capsularis lining the gestational sac, and the other one is surrounding this. It is varietalis, decidua varietalis. It is not 360 degrees, but it is surrounding the endometrium and lining the endometrium. Between them, there is one hypoechoic line, and this is fluid in the endometrium. So the very good difference is to see these two decidua, double decidual sac sign will differentiate between true gestational sac and pseudo-gestational sac. In opposite, here is the pseudo-gestational sac. Endometrium is thick and irregular, and fluid is intracavitary. The fluid is here, it is intracavitary. But keep in mind that only 10% of ectopic pregnancy show pseudo-gestational sac, and half of the intrauterine pregnancy show double decidual sac sign. Therefore, in a woman with positive beta-HCG, non-specific fluid collection in the uterus most likely is a gestational sac. The other confusions is to differentiate corpus luteum from the ectopic pregnancy. And the cornerstone for this is to determine whether the lesion is intracavitary or intra-ovarian. Sorry, it's intra-ovarian or extra-ovarian. Corpus luteal cyst is intra-ovarian cyst showing thin or thick, sometimes contain echogenic debris in it. We need to make sure it is in the ovary. It is given what is known as a close sign. Close sign is the radiological sign of that normal parenchyma extending around the that the mass arises from the solid structure and not adjacent to the area of the adjacent to the area of the ovary or the area of the original mass. So we use this close sign to differentiate between the corpus luteal cyst and the ectopic pregnancy. This is a video clip. Let me. This is a video clip showing cystic lesion. Let us see here. This is a cystic lesion with thin wall and echogenic wall, and there is clear fluid in it. But as you move a little bit to the left adnexa, you will see a little bit to the left adnexa here. Yes, sorry, a little bit to the left, you can see thick and echogenic wall looking like a donut. This is, let me play it again. So this is a donut looking like lesion. And here is the ring of the fire. And this is the corpus luteal cyst. So the corpus luteal cyst, and this is the ectopic pregnancy. And so we need to differentiate between ectopic pregnancy and corpus luteal cyst to decide real corpus, the real ectopic pregnancy. And look here, this is intercavitary lesion, showing giving close sign, and this is corpus luteal cyst. But look here, in the ectopic pregnancy, the tubal ring is here. This is the tubal ring. Outside margins of the ovary, there is hyperechoic line separating the ovary and the ectopic pregnancy mass. Again, this is another helpful thing to look at the thickness of the wall of ectopic pregnancy. Here it is thicker and more echogenic than the corpus luteal cyst of the because of the trophoblastic tissue. Here is the corpus luteal cyst. When comparing with the ectopic pregnancy, it is thin and this is thick. This is less echogenic and this is more echogenic because of trophoblastic tissue. And sometimes you need to use what is called a dynamic scan. And this is by pressing the transducer in the area of the breast and to separate ring or mass from the ovary. Look here. You will see tubal ring is separate and getting away and moving separately from the ovary. But the color Doppler is not helpful to differentiate between corpus luteal and ectopic pregnancy. Both can show firing with high versatility index and end diastolic velocity. Look here, this is corpus luteal cyst and this is tubal ring containing a live embryo. Both shows firing. Also, it is more apparent in the ectopic pregnancy because of trophoblastic blood flow. But finally, this ring fire will add not much value to the diagnosis of the ectopic pregnancy. Then let us move to the unusual locations of ectopic pregnancy. As we mentioned before, the vast majority of ectopic pregnancies are implanted in the fallopian tube, and approximately of 4% of all ectopic pregnancies are found out of the place in more unusual locations. These unusual sites of implantation include the interstitial portion of the fallopian tube and area of the cervix, ovary, Cesarean section scar, and even abdominal area. Interstitial, or sometimes it is known as a Cornual ectopic pregnancy. It accounts for 4% of all ectopic pregnancies. And the most common site of unusual ectopic pregnancies, it occurs within the interstitial portion of the fallopian tube. where the fallopian tube crosses the uterine horns. It is covered by myometrium. So therefore, it has the potential to grow to larger size than the typical tubal ectopic pregnancies by the time of presentation. Usually it is presented at later gestational age, between 10 to 13 weeks. Therefore, the risk and severity of hemorrhage are very high. Because of it is growing more, it is the risk and severity of hemorrhage are going very high. It is vital. Look here in this image, we can see the uterus in sagittal. The endometrium is empty and free. There is no free fluid in the endometrium. Also, if we see the myometrial area, it is almost equal in size on both sides. On transverse view, this is gestational sac in extremely eccentric location and bulges beyond the superolateral serosal surface of the uterine fundus. And here at the lateral area, there is not much myometrium. There is a space between the endometrium and the gestational sac. The endometrium and the gestational sac, there is a space between them. And here there is no more myometrium behind or at the lateral side of the gestational sac. These findings are highly suggestive of interstitial ectopic pregnancy. Another example of interstitial ectopic pregnancy, here is the gestational sac. It is in the extremely eccentric location, and there is clear separate the endometrium and the gestational sac. There is here there is no myometrium at the lateral side of the gestational sac. And another example of interstitial ectopic pregnancy, here is the gestational sac containing embryo. And look here, there is myometrial tissue separating the medial margin of the gestational sac and the endometrium. And peripherally, there is the gestational sac has no visible myometrial tissue. So if you see there is a space between the endometrium and the gestational sac, and there is no myometrium at the lateral side of the gestational sac, then this is a strong sign of interstitial ectopic pregnancy. Let us see cervical ectopic pregnancy. It is very and fertilized ovum implants directly into the wall of the cervix below the level of the internal cervical os and above the cervical below the level and above the external os. And sometimes it is difficult to distinguish the cervical ectopic pregnancy from abortion in progress or inevitable abortion, because both of them, they will show nearly a gestational sac at the area of the cervix. So you need to make sure that this is not abortion in progress. Here you can see empty uterus at the area of the fundus. The endometrium is almost thin, and no gestational sac at the area of the fundus. At the cervix, which is here, you can see gestational sac, a thick and echogenic wall containing yolk sac and a small embryo. And this is a patient came to the emergency department with pain and bleeding. Her ultrasound shows retroverted uterus. Endometrium has no residual reaction, no gestational sac within the endometrial cavity. At the area of the cervix, there was irregular gestational sac containing yolk sac, with no fetal ball or embryo in the gestational sac. 2 days later, gestational sac is identified again here, 2 days later, gestational sacs identified again, and it is increasing in size. Also, there is still there is a yolk sac, also increasing in size, but no yolk sac, no embryo in it. No embryo, still no embryo in it. The sac was non-mobile upon manipulation by transvaginal probe, no free fluid in the cervical canal or in the cul-de-sac. These findings strongly suggest cervical ectopic pregnancy. What about this image? Oval shape, flattened gestational sac with thin wall. The cervical canal here, in the cervical canal, this is flattened. These represent abortion in progress because it's thin, and it is within the endometrium, within the cervical canal, not eccentric position of the cervical canal. And at the fundus, we can see echogenic material and echogenic products in the area of the fundus. This is retained some of collapse and hemorrhage. So therefore, if you see in the cervical area, well-formed sac with prominent echogenic wall that contains yolk sac and or embryo, the diagnosis is cervical ectopic pregnancy in most likely. But if you see flattened irregular sac located within the cervical canal, not eccentric position, and there is no embryo, then the diagnosis could be abortion in progress. Ovarian ectopic pregnancy is also very rare. It accounts for 1% of all ectopic pregnancies, and it is difficult to diagnose because it can be confused with the corpus luteum. So you need to differentiate between the corpus luteum cyst and if it is real ectopic pregnancy. And the only way to do this is to see yolk sac or embryo within the lesion of the ectopic pregnancy. Look at this. This can be ovarian cyst, or it can be also ovarian ectopic pregnancy. There is here some echogenic internal echo, and this might suggest yolk sac. But actually, this is a corpus luteal cyst with internal debris. And this is an example of ovarian ectopic. The only way to confirm is to see yolk sac and embryo. The only way to confirm is to see yolk sac and embryo. And the cystic lesion in ovary. And here we can see the color Doppler is showing heartbeat within the embryo. And also it is showing the ring fire. Abdominal ectopic pregnancy is extremely also rare. It's for less than 1% of all ectopic pregnancies. It can be primary or secondary. Primary, it can be as a result of implantation of the abdominal fertilization of an ovum with subsequent direct implantation to the conceptus outside of the genital tract. Or it can be secondary as a survival of a ruptured ectopic pregnancy that implants into the abdominal organs. Look here, this is the uterus in sagittal view. It is empty, there is no any sign of pregnancy. There is no fluid in the endometrium. And here, there is outside of the uterus, you can see the placenta that's not attached into a myometrium, but attached to the serosal area, the posterior serosal area of the uterus. And here we can see gestation, we can see abdominal, the abdomen of the fetus. And this was this fetus noted here outside in the left hemipelvic area. So take as a rule, if this live large fetus outside the confines of the uterine cavity, it is almost certainly a sign of abdominal ectopic pregnancy. Cesarean section ectopic pregnancy, and also it is also very rare, and this might occur when it is implanted in cesarean section scar at the anterior wall of the lower uterine segment. This is increased in the recent years as a result of increased rate of cesarean deliveries. So here is the gestation, here is the uterus, the endometrium. The endometrial line is empty, and here is the external os. Here is the external os of the cervix, and just above the internal os, anterior to the we can see a gestational sac containing yolk sac. The location of sac within the myometrium of the lower segment, and the scar tissue seen extending the endometrial cavity from the anterior to the endometrial cavity. This will give you a clue or a sign, a strong sign that this is implanted in the cesarean section scar. This is another image or another patient with 2 period cesarean deliveries. The gestational sac is low and it is in eccentric position with the endometrial cavity. Here, when we see the careful visualization of the or careful examination of the cervix, will show that this is above the cervical area, the cervix of the endometrial, cervix of the uterus area, and just at the area of the location of the cesarean section that extended from the anterior wall to the posterior wall, we can see a gestational sac that contains yolk sac. So whenever you see, whenever you think this is ectopic pregnancy, look at the cervix and look also at the area of the fundus and make sure that it is the area of the cesarean section scar, and also correlate with the history of superior cesarean section scar. Finally, we will discuss the heterotopic pregnancy. Heterotopic pregnancy is another very rare situation where there is an intrauterine and extrauterine pregnancy occurring simultaneously. This is a uterus containing gestational sac with an embryo, and we can see another gestational sac outside of the uterus at the left adnexa. There is a gestational sac containing and uterus. So this is heterotopic pregnancy. This is intrauterine and this is extrauterine ectopic pregnancy. This is another patient with heterotopic pregnancy. Here is the uterus containing gestational sac and yolk sac. And just to right adnexa, this an gestational sac with equal, and here showing embryo. And around this gestational sac or tubal ring, which is material. This echogenic material represents in the area of the cul-de-sac. So in summary, ectopic pregnancy has a valuable sonographic presentation and location. Confirming the presence of intrauterine pregnancy is the best negative predictor in the patient at risk for ectopic pregnancy. Negative pelvic ultrasound in the at-risk patients still have 5% chance of ectopic pregnancy, especially at low levels of Therefore, serial ultrasound examination might be required to clarify diagnosis and monitor treatment. Thank you.